Jessica McCurda, and we're co-chairs of Our World, Our Vote, a nonpartisan, student-run political engagement initiative through the Rochester Center for Community Leadership. The Rochester Center for Community Leadership, as part of the College Dean of Students Office, educates students to become active leaders in their communities. We'd like to thank first Glenn Circelletti, Director of RCCL, and our panelists for planning and contributing to this event.
And we're here tonight to have our panelists, who are experts on the issue, deconstruct the current problems that are facing, that people are facing with the healthcare reform issues. So what is the current legislation in Washington? What are the problems that people are having with it? And what is all the confusion about? And what are your questions about it? So they'll start off speaking about the issues from their own experience and expertise, and then we'll move on to questions from you as audience members for the panelists. So, and we now present to you our panelists.
Our first panelist, Stephen I. Goldstein, is President and Chief Executive Officer for Strong Memorial Hospital and Highland Hospital, Vice President for the University of Rochester Medical Center, and President for Long-Term Care. He is also Professor in Community and Preventative Medicine for the University of Rochester School of Medicine and Dentistry. Mr. Goldstein was recently elected to the Board of Trustees for the American Hospital Association and is currently chair of the Rochester Regional Hospital Association Board of Directors. Mr. Goldstein received his master's degree from St. Louis University Graduate School of Hospital and Healthcare Administration.
James Fatola is Associate Professor and Chair of the Department of Public Administration at the State University of New York at Rockport. He teaches graduate courses in the MPA program in healthcare policy, Medicare and Medicaid, nonprofit organizations, and ethics. He received his PhD from Fordham University in ethics and public policy. Prior to his appointment at the College at Rockport, he worked at the executive level at both the New York State Department of Health and the Federal Healthcare Financing Administration. He has particular expertise in Medicare and Medicaid. Professor Fatola is a regular guest on healthcare reform issues on Bob Smith's 1370 Connection radio show on WXXI-AM.
And lastly, Theodore Brown is a professor in the History Department as well as a professor of Community and Preventative Medicine at the University of Rochester. He received his PhD from Princeton University. His research falls into several areas: the history of American psychiatry and psychopsychomic medicine, the influence of organized philanthropy on medical research, health policy, and medical education, domestic and international health policy, and the history of American and global public health. Professor Brown teaches courses in the history of medicine, public health, and health policy at both the undergraduate and graduate levels. And we'll leave it to our panelists now.
Well, good evening. Thanks for coming. As was mentioned, my name is Steve Goldstein, and I'm kind of the grizzled hospital administrator. I've been in the community 28 years. I used to be president of Rochester General. I've really had the honor now of being president of 3 of the 4 hospitals in Rochester, which is, Jim and I were just talking, is somewhat unique in our field. And now I have a chance to spend a lot of time going around the country with the American Hospital Association, just looking at what's happening to the institutions, what this revolution is about. And I'm really going to talk about health reform as a revolution. And it's one of the most, from our vantage points, one of the most exciting, and in some respects, one of the most scary and most challenging things that we will face. And you, as up-and-coming entrepreneurs and members of the working class, are going to have a chance to really be a vital part of this. So I wanted to just spend about 10 minutes, very, very quickly. I'm really going to race through and frame, I think, what's going on right now in Congress and what some of the issues are. First, I just want to mention, reform is not new. It started in 46, it was talked about again in 49, 62, 64, 65, 74, 79. I was involved in it in the 90s, also I guess in the late 70s, and of course now. We're the only industrialized country that does not mandate access to health insurance for all of our citizens. And we spend about 16% of our GPN for GPD, for health care. And nearly 15% of our population, 48 million people, do not have insurance. Now, I should mention that does not mean that they don't get health care. All 50 states require that their hospitals, and there are roughly 4,800 hospitals in the United States, accept patients regardless of their ability to pay, stabilize them, and provide whatever services are necessary. President Obama has been very focused on dealing with healthcare as a solution to one of the nation's greatest problems, which is the economy. And a few months back, I think it was in February, passed the American Recovery Reinvestment Act, which was a stimulus program that laid the foundation for what you're watching today. That was $787 billion. We're now starting to talk about billions and trillions, like when I was in college, we talked about millions. It's quite phenomenal. And there's been a lot of focus around comparative effectiveness research and investments in that, and that is an issue that's going to become very important. What is appropriate to do in the care of medicine? A lot of workforce, a lot of prevention and wellness. We are a country and institutions that are based on tertiary care, certainly strong as a university academic medical center, with tertiary and quaternary programs from primary care to transplant. And so that the country is really now going to grapple with how to structure healthcare. This has become the #1 domestic issue, and the president right now has based his entire presidency on the resolution and the passage of a bill. And there is, when you go to Congress, this is it. There isn't a lot else that's getting discussed. It's quite fascinating. And as I mentioned, in order to cover some roughly 48 million people, it's been estimated that we'd have to spend about $1 trillion, although I will tell you that the AUKUS bill is somewhere around $800 billion, and we'll see where that plays out. Now, the president has promised to do this without adding to the deficit, and that's where the rubber hits the road. This is just a quick slide to show you about what's been happening on the gross domestic product from 1960 to 2007. What the Congressional Budget Office has shown, which is that if we don't get a handle on Medicare and Medicaid, and Jim is actually an expert in this, and I'm sure we'll be talking about it, that point in fact we will potentially bankrupt our country. And in fact today, the Hospital Insurance Trust Fund is paying out more than it collects, and it will be depleted by the year 2017, which is 2 years earlier than projected. And this represents an enormous problem as Medicare is headed for bankruptcy. The total issue that you'll hear in the press, and the phrase that you want to concentrate on, is called bending the curve. Whenever we talk about any of these legislations, the issue that has to happen is we have to bend the cost curve. And that's going to require a revolution in the way we take care of people and provide services to people, and an enormous change in how we do that. If we're going to reduce the growth of healthcare expenses, and we have to reduce it from its current 6.7% to around 4.3%, and it's projected by the administration that would save some $3 trillion. Now there are right now there are a bunch of issues both in the House of Representatives, I'll talk about that, as well as the Senate. The House has passed a bill. It's called the American Affordable Health Choices Act of 2009, and it provides universal coverage and reduced health care costs. The Senate has two bills from the Health, Education, and Pension Committee, the Health Committee, which had been chaired by the late Senator Kennedy, and the Finance Committee, which is Senator Baucus's bill. These bills were passed. The Health Committee bill was passed in July, and just recently, 9/15, Baucus moved to what's called markup of his bill. And they now will get reconciled through the conference committee if the Senate can get 60 votes. And you'll see a lot of talk about 51 votes. There is in the original bill an opportunity for 51 votes to allow a budget reconciliation. But what the administration really wants is 60 votes. That would allow the Republicans not to have to filibuster. And that's why they really approached this whole issue of having a number of Republicans support this bill, and yet to happen, but they're working very hard at it. Common provisions between the House and the Senate. Medicaid expansions. This is an issue that the states, if you read the Democratic Chronicle about last Saturday, they did a nice article on what the impact is of Medicaid. It would cost New York State more, and Jim will, I'm I'm sure, talk a little bit about Medicaid. Medicaid's a huge issue in New York State. 37% of state budgets goes to Medicaid payment, and it's been an area of great concern to the institutions. Means-based subsidies is part of the bill, common provisions, cuts to Medicare and Medicaid, where we are as providers, huge cuts. Individual employer mandates, personal responsibility, that means you'll have to buy insurance, that means that insurers, that companies will have to provide as well. Creation of new insurance exchange with or without a public option, and insurance market reform, which really has to do with their inability to exclude conditions, create caps, etc. Divergent positions is the public plan option, which I'm sure you've been reading about. It is in the House bill. It creates a public plan. Pelosi has talked about this quite a bit. Representative Pelosi is Speaker of the House. And it's meant to compete with commercial insurers. And I will show you a slide that this, they want to price these public options at around Medicare plus 5%. In our institutions, that would cost us roughly $81 million. When I say ours, I mean Highland and Strong Memorial, $81 million per year. And so that has a dramatic impact. One of the things that you should understand is that we live in a world where Medicaid pays the hospitals 23 cents less on a dollar. So they're short 23 cents. Medicare, in Strong's case, is short, it pays 94 cents on a dollar. And third parties pay above that, and that's based on negotiations. And that's what's called cost shifting. If cost shifting was reduced from, we went to a public option and it paid just Medicare, it would be about $34 billion across America. So it's a very, very significant issue for the institutions. Within the Senate bill, there's what's called a co-op, and these are, in essence, tax-exempt member-run health plans that offer consumer-focused alternatives to existing health plans, where you would actually look up and try and choose. Both bills have to figure out how to raise money. They do it through excise taxes on very expensive health care plans, as well as taxing individuals that make incomes above $280,000, married couples over $350,000. That originally was going to be brought down to $60,000 at one point, and there was a great deal of protest in these town meetings. One of the most hotly debated provisions of the House is the public option. And in essence, as I mentioned, it's a publicly run insurance plan which competes with the the commercial insurers. And many of the critics claim that this is the first step of a single-payer system, and I'm sure we'll talk a little bit about the virtues, et cetera, and negatives of a single-payer system. But the theory is that this would be a competitive to insurers. They would be paid less Medicare rates, and that would draw down the price of the other insurers that are currently being paid more. I mentioned Strong. Both proposals call for significant modifications of the current payment system, market basket reductions, that's inflation for products. In Strong case, the House bill would actually reduce $165 million over 10 years, and the Senate bill is significantly less, about $31 million. They would change disproportionate share. You'll hear about that. Hospitals are reimbursed some amount for those patients that either cannot pay or are underpaying, only have partial insurance. But the theory being that since more people would be covered, hospitals should receive less, or clinics or whatever it might be, because they have more paying customers. There have been a lot of conversations about readmission penalties. 18% of all the admissions in Medicare are readmissions within a 30-day period. This costs about $15 billion a year. There's an effort to reduce that and take out about $12 billion of that. So there'll be a lot of focus on what does it take to make sure patients are not readmitted within a certain period. An issue that you'll hear a lot about is called value-based purchasing, pay for performance. We're going to be looked at we'll only get paid if we have high outcomes for cardiac services, for orthopedic services, for medical services. And those institutions that don't have as good outcomes will have penalties, and that'll pay the total pot, which will be about 2%. Payment bundling. We'll be taking long-term care and acute care institutions and bundle those payments so that when patients go between long-term care and acute care, they only get paid once. And the purpose there is not to have patients go back and forth and have multiple payments. Graduate medical education, there has to be shifts in that if we're going to provide for primary care and other services. Physicians are finding themselves quite a bit under the gun. It's not the world that they thought they were entering when they started their training, and there's a real concern with the retirement of this group coming up that there simply aren't enough primary care physicians. There's tremendous diversity of wage changes and outcome changes throughout the United States, so there's a look of what are geographic variations, why are some areas better than others, and there has been talk of the creation of an independent advisory council to set payment rates. Now, while all these negotiations continue, key issues of consensus do exist. There will be coverage of 95 to 97%, but that could still result in around 21 million people that are not covered, particularly illegal aliens. And if you watch the President speak, Congressman Wilson has something to say about that comment about illegal aliens. But the Republicans do not want to see that covered. There will be employer contributions, individual contributions, Medicaid expansions, federal subsidy to help individuals purchase coverage, creation of insurance exchanges of some sort, insurance reform. Right now the President is really attacking the insurance industry. A lot of it is as you read anecdotes, a real concern to the public. Incentives for quality of care. We clearly will be paid for how well we do. And that means that the public has to have a responsibility for preventive care, dealing with obesity, other kinds of issues. Restrictions on physicians' ability to self-refer, Medicaid and Medicare providers, and lots of new taxes. At the best, when they talk about all of these issues, it would take about $500 billion out of the system, and that means there'd have to be about $500 billion of new taxes. Hospitals, remember why we're here. Our issue is reform and making sure that we can deliver quality care to our public, and value-based purchasing is something that we really do support and would like to see. We're also very supportive of insurance market reform, the elimination of pre-existing condition clauses and administrative simplification, etc. Now, I did want to just show two quick slides. New York State, in all of this, we have 217 hospitals in New York State, and New York State is one of the worst performing states from an operating line point of view. So they're going to have to transform the care that they provide with less assets and less resources than other states have. In 2008, when you aggregate all of the hospitals, they lost money. I will tell you that Strong and Highland are two of the most successful hospitals, but a lot of that has to do with our regional programs and our ability to provide service. New York State fits just above Mississippi in its bottom line margin, and is number 2 from the bottom. So, in summary, over the next 20 years, it's really going to be a revolutionary change. We can't afford the system that we have. We have to pay for quality. We have to encourage people to seek careers in areas where they're needed. We have to change the way we deliver care, we insure it, and all of this has to be done in a much more cost-effective way. We are literally bankrupting the system. The federal government will play a much larger role in public policy in the future, even in a state like New York, where New York State has such a presence, the Department of Health has such a presence in institutions. And institutional providers to survive will need to meet the challenges of these changes, which will mean collaborations, changes in their organizations, changes with their relationships with their physicians, with their employees, with unions, et cetera, et cetera. So it's a very exciting time, and in the scope of these two bills, you're watching the change that America looks at medicine. Thank you.
Okay, I hate standing behind a lectern, so if you can hear me, can I come up front? Is that all right? So I hate, if you can hear me, fine. So I'm Jim Petrola. Thank you for graciously inviting me to your campus to engage in this conversation with you. I hope that I'll leave something for you to think about and to act on as a result of this dialogue that we're having here. The White House homepage itself has a blurb, "The President's Plan in 4 minutes." Fortunately, we've been given 10 minutes to explain the issues and their solutions. Whew. So I'm pleased about having a little more time than that. So I have a challenge for you tonight, for all of us, so you may not exactly be happy with what I'm going to say. I'm going to stay in front of this, I see. I want to help frame the healthcare debate in a discussion with you, a dialogue with you, based on another similar pressing issue, namely the global warming, the environment, and sustainability. The President has said, rightly, that the status quo in healthcare is unacceptable and it's unsustainable. For the past 30 years, healthcare spending has been growing more rapidly than the growth in our economy. Currently, healthcare consumes about over 17% of our economy, of our gross domestic product. And over the coming decades, it is projected that if we continue on this path, healthcare is projected to consume, in 70 years, 49% of our economy. That is the path that we're on. That half of our income, of our total income in our economy, if we stay on the path that we're currently on, will be devoted to healthcare spending. That is the definition of unsustainability. We know that there are winners and losers, in a classic political science sense, in the current status quo of healthcare. And change means a different set of winners and losers. And so we have these fights in Congress from particular interests, a lot of interest, about who's going to be worse off, who will bear the cost because of proposed reforms. It's interesting, here we are, I didn't know this, here we are at Wilson Commons, and I want to bring to your attention a classic article by Garrett Hardin called "The Tragedy of the Commons." And so let me use this as a metaphor because it applies to the environment and global warming and therefore also to healthcare from my perspective here. That article describes a dilemma in which multiple individuals acting independently and solely and rationally consulting their self-interests, how they'll ultimately destroy a shared limited resource, even when it's clear that it's not in anyone's long-term interest for this to happen. So he uses a hypothetical example of a medieval land tenure in Europe. So he just makes up this example. He talks about herders who have a common parcel of land called the commons, and they share the commons for grazing their cows. And so in the example, it's in each herder's interest to put the next, and any additional cows that they have, they put them onto the land, even if the carrying capacity of the commons is exceeded and it's damaged as a result of it. So everybody uses the commons and continually adds their cows to graze on the commons, and nobody's responsible for the commons. Each herder receives all of the benefits from an additional cow grazing on the commons, while the damage to the commons is shared by the entire group. Does this sound familiar in terms of the global economy, global warming? If all the herders make their individually rational economic decision, the commons will be destroyed to the detriment of all. We're all meeting our self-interest there. This is the debate over global warming, the debate over the environment and sustainability. This, I think, is also the debate over healthcare reform and a sustainable healthcare system. I'm reminded of the Federalist Papers, number 10, written by Madison, for those of you in a political science background. Number 10 addresses the question of how to guard against factions, or groups of citizens with interests contrary to the rights of others or to the interests of the whole community. We've been dealing with those factions, those special interests, from the founding of this nation. That is the way we do politics in this country since day one. So my point is that we all have these interests grazing at the commons of healthcare. We do, all pursuing our self-interest with no one accepting responsibility for the commons. That's the dilemma that we face in global warming. That's the dilemma that we face in healthcare. So we can certainly focus on how healthcare reform affects you as students and in general young people. So I'm prepared to talk to you about that as another, and you can just be another interest group among many interest groups, among many of the factions, all worrying about how we deal and grazing on the commons here. And so I can certainly talk to you about how will you as young people, as students, be affected by potential healthcare reform. But following Hardin and Madison, may I humbly suggest that your challenge, our challenge, is not to ask only how healthcare reform will affect me or us, our individual interests. Of course we need to ask that. But also we need to ask, how will it affect us overall, in common, as a society? Let me explain why this is the case for you in particular. What are your interests in healthcare? It can't be just what your interests are as students. You have parents, you have grandparents, you will have families and children, you will work in a variety of settings in the future. All of them, all of us, have a stake in a beneficial outcome from this debate. And it's not just what benefits us now, but also in the future when our circumstances change. To use a phrase of the President's, we all have skin in the game, and each one of us, and all of us together. So what do we need to do to have a sustainable healthcare system over the long term? And I can tell you, and as Steve has mentioned, we are on a path of unsustainability. You and all the rest of us will be asked to share in the cost and the burden of reform so that we can all be better off here. There are plenty of villains, plenty of culprits out there. Greedy health insurance companies, greedy or inefficient healthcare providers, greedy pharmaceutical companies, inefficient government, just as there were real villains and culprits in global warming. We know that. But we have met the enemy, and he is also us. We cannot absolve ourselves, the citizenry, each of us, from our own responsibilities in contributing to global warming and in contributing to the ongoing healthcare crisis. That's the message that I want to leave with you. So make no mistake about it, we will be affected by what's legislated or not. It's still not clear what will happen. I'm not at all confident that we'll get what we expect from legislation in healthcare reform. What is decided or not in the current healthcare reform debate has very significant consequences to you, young people, and all of us now and in the future. There is a lot at stake in getting this right. If we don't address rising cost of healthcare, our standard of living will be lower in the future. We will be paying much higher taxes, and we will have a lower discretionary income as a result, and we will have less resources available to spend on other important priorities. Like global warming and the environment, it is not enough just to focus solely on the villains. And surely there are plenty of villains involved. Of course there are. We cannot have a sustainable healthcare system unless each of us is more conscientious about our use of the healthcare commons and reduces our healthcare footprint. Let's begin now, each of us. Thank you.